I think, hey, if there are any professional producers out there, could you come and give us a hand? That would be great. It is Thursday night, 7 o'clock, so it is time for FUB Club Live. Any questions, please do let me know your questions live. You've emailed in a few already, and we will crack on with this. How have you all been doing? I'd love to hear your news. I'd love to hear you getting on. I am joined by the lovely Mrs. UB.
Hello.
In the corner. Hello you. Hey stranger, how are you doing? You're looking very, very snazzy in your new profile picture. Can I wave at you? It's not letting me. There you go. I'll wave at you too. Good to see you. I'm excited. We are operating tomorrow, and this is a bit of a red letter day because actually being able to say we're operating tomorrow is not that common an event these days. Okay, so I'm not allowed to talk about operating. So anyway, so let's go to the first of our questions that you've been in touch with. And my surgery story, we love you. We haven't seen you for a little bit. I hope you're doing well. Has said that, okay, I have just heard the term stacked mastopexy. Hey, it's you. Hey, hello. I'm just answering your question. So I have just heard the term stacked mastopexy. Is this just another name? Hi, back to you. Is this just another name for an auto-augmentation mastopexy, as they sound very similar? Yeah, there's a lot of things with the same name in plastic surgery, and stacked mastopexy and auto-augmentation, as far as I'm concerned, are an example of that. So a mastopexy is a breast uplift, and a breast uplift involves various things of skin tightening and readjustment of the breast inside, maybe moving bits of it to various places, or tightening or plicating them. And the principle here is that we are trying to convert the dimensions of a breast that you don't want to the dimensions of a breast that you do want. So, okay, breast, it's a 3D object. It's got width, it's got height, it's got projection. And what makes a pretty breast is preserving projection, not necessarily preserving width, you don't want that, and not preserving length. And so there are things that we can do to convert those quotes unwanted dimensions to more wanted ones, more desirable ones. So when it comes to changing length to projection, one of the ways of doing that is an auto-augmentation mastopexy. So a bit of the breast that was droopy, can leave it attached and hinged, but we can sort of rotate it upwards and wrap the rest of the breast around it, and you get a more projecting breast. And stacked seems to be another term from that. I think the term stacked mastopexy has been stolen from the breast reconstruction world. So in breast reconstruction, there are many methods of doing it, and one of the methods is to use a free flap from somewhere else. So a free flap is a bit of your body that is removed from your body and then transplanted to the chest. Its blood vessels have been carefully dissected out, and they are reattached under a microscope so that they're going again, and all very nice. Now, these free flaps are different depending on what the experience is, the unit that you use, and your availability anatomically. I used to love doing DIEP free flaps, where you take the tummy and you move those to the chest, and there are many others. Another nice one is something called the tug flap, or the TMG flap, which is a flap taken from the inside of the thigh, and it just leaves a scar on the inside of the thigh. The trouble with some of those is that they are quite small, and if you want to reconstruct a reasonably sized breast, it may not give you enough volume. And so you might use 2 free flaps. And in those situations, you may put one next to each other, or you may put one on top of each other, in which case it's called a stacked flap. So I think sort of stacked mastopexy is borrowed from that sort of stacked free flap option, but the principle is the same. You're just sort of adding layers of tissue on top of each other rather than sort of sliding them or moving them in some other way. So that's it. As far as I'm aware, they are exactly the same term. Then a whole load of questions just coming in and comments and stuff. So let me just run through those. So my surgery story, does that answer your question? I hope it does. Claudia with a chance of rain. Hey, Claudia with a chance of rain. Do you do tear through, but I think you mean tear trough in your Windsor clinic, or do we tear through our Windsor clinic? Well, sometimes we tear through our Windsor clinic, and we do indeed do tear troughs in our Windsor.
Claudia.
You might be Claudia. Oh God, that makes a lot of sense, doesn't it? She just rolled her eyes at me. Sorry, Claudia with a chance of rain. Hello, that's a much more clever name. Thank you. Yeah, so the tear trough. The tear trough is this bit here. So it's this sort of indentation, and sometimes if you've got sort of fullness of this fat pad underneath, you can get an eye bag underneath it, and it sort of literally catches what?
It's a lovely demonstration.
Do you like it? Am I illustrating this story nicely? And one of the really, really nice ways of rejuvenating the face is to address a tear trough if it's excessive. Now, what happens in a face? A young face is meant to have nice volume up here. And you can see when my volume is up here, then it's kind of looking all, yes, I mean the injection to improve the dark circles indentation. I got it. Thanks, Claudia. So volume is meant to be held up here nicely, and that's how you start off in your sort of youth in your 20s. Now what happens is those fat compartments gradually deflate and gradually sag, and as they sag, they empty the top bit of the compartment and they fill the lower bit of the compartment. So the lower bit of the compartment will be something like what we then call this nasolabial fold. Boom, that's full. And it could be a marionette line. Boom, that's full. Or it could be a jowl. And the bit that it's leaving behind becomes unmasked. So here we have the orbital rim, the bony rim. And so you get this combination of a really full fold and a really empty, hollow orbital rim there. So one of the components of making that look a lot better is to just sort of, just to disguise, just to blunt that orbital rim there, just to sort of smooth it in a bit better. Hello, back at you. Yeah. That's called tear trough filler. And you've got to be so careful with tear trough filler. That there is some filler that is kind of relatively straightforward for most injectors, and I'd say cheeks are relatively straightforward for most injectors. Tear trough is one of the sort of A-level filling areas, and I would say that this area here is degree level or PhD level. That's the hardest bit. And I say this is A-level because the skin here is so thin for a start that if you just insert filler in there and it's too close to the surface, then at best you can end up looking like you've got a little slug underneath your eye, which is not a great look. Not that many people come in saying, I would like to look like I've got a slug under my eye. But at worst, it can cause really serious problems, vascular problems, problems with your eye movement. But it can also cause this weird thing called a Tyndall effect. And I find it kind of hard to explain, but it's where light shines through the eye and bounces back again. And it hits filler if it's too superficial and changes the color of the reflection. And it looks blue-grayish. It's the same reason the sky is blue. It's just because of diffraction of light rather than there being anything blue in the sky. And when that's happening under your eye, it's not great because someone comes to you because they've got dark circles and you give them filler and you've got worse dark circles. So the solution to this is to go really deep, down onto orbital rim, down onto bone. Because we're playing around with a lot of interesting clockwork, I never do it sharp. You've got to use a blunt-tipped needle. It's not really a needle, it's called a cannula. And just do little pepper pot injections around this region, just to very gently soften it. And I'd rather under-treat and see you twice than over-treat and have a disaster to sort out. If we end up seeing you twice and augmenting it, then there is no additional charge for that. That's just all part of the same. We are going to treat your tear troughs, but it's just a more prudent, natural, lovely way of doing it. And the results can be just staggering. I will post some photos of the kind of results that we see with this kind of thing. It's really, really nice rejuvenating treatment. It's one of my favorite filler treatments, actually, because it has such great effects. You just got to take it gently, got to take it calmly. So that's that. Anything, Claudia? No, that's it. Okay, cool. High B sleeve, high back at you. What would make the difference between a 360 and extended tummy tuck? How do you differentiate between the two for a patient? Right. Okay. So you've got all the terminology. I like it. So a tummy tuck involves a scar, a low scar, usually from around hip to hip. A 270, I don't massively like the term 270 tummy tuck because it implies it's sort of 270 degrees of a circle, and it may not be, but it's something that's more extended than the normal 180 tummy tuck. It extends around the back. to a degree. And if it's a 360 tummy tuck, it actually touches in the middle. I don't do so many 360 tummy tucks because it's not normally indicated. And when I do, I kind of like want to take it off like a hula hoop in one piece until you start doing it, and it makes it unnecessarily devilishly difficult. And so I sort of give up, but then I always regret it at the end. I think I could have done that.
It's like when you peel an orange.
It's like trying to peel an orange in one piece, but it kind of does make things more difficult than they need to be. You kind of don't need extra stuff, so you take it all off in one piece. You don't take it all off in one piece, rather you take it off in two pieces. So when would we do one or the other? Okay, so decision making about how long this tummy tuck scar is, since it's so variable anyway, how do we ever decide? The trick I like to do, so I'll get someone, I examine them, I work out where I want their scar to be, and then, I mean, picture the scene. You are there. You are, to a great extent, undressed. Your tummy is out, and you hate your tummy, which is why you're seeing me in the first place. And then I get you sitting over the edge of the couch. You're sitting there, and I'm saying, right, I'm looking for your tummy crease. You're mortified, and you're thinking, oh, I hate this. And I'm looking for your tummy crease. So you're sat down, and I want to see where the crease of your tummy ends. And it's quite helpful. I just draw it, I mark it. That illustrates to you, look, if I were to end my scar 2 inches before that, then you'll have a great big knobble after it. And no one wants a great big knobble afterward. So that's where your scar has to be. In fact, it has to go a bit further than that so that we can sort of fade it out into the remaining unknobbly areas. That's a technical term. So that's the minimum the scar needs to be. And sometimes that wraps around more. And if it wraps around more, then fine, it's an extended tummy tuck, so-called 270. Now, in some people, you get a hint that they would do well for a 360 from their history. If they've lost a huge amount of weight, massive, huge amount of weight, then you might be wrapping all the way around their tummy. If you cannot find the end of this scar, if everywhere is loose and you join in the midline, then you may be doing a 360. But under those circumstances, as my last minute check, I want to make sure I can grab a really good amount of tissue above the buttock whilst the patient is slightly bending forwards. Because if you can't grab, if there's not enough to take away in that position when the patient is slightly bending forwards, then you're not going to be able to close a 360, because during a tummy tuck, you need to flex the patient. They actually are flexing forwards to close them at the front. So if that makes them too tight to close at the back, then you're not going to do a 360. So that's why really there aren't that many people, even after huge amounts of weight loss, not that many people really need a 360 tummy tuck, but a few do. I am going to probably give you a longer scar if you're a man than if you're a woman, or if you're a woman who wants to de-emphasize her hips rather than emphasize them. Because if you have a shorter scar as a woman, then that will tend to exaggerate the waist and therefore increase the difference between the waist and the hips. If you have a longer scar, then you're able to close your wound in a more vertical downwards direction, which tends to square off the trunk. So if I have a woman who says, oh, I hate my hips, can't stand my hips, then I'll probably go a bit longer than I otherwise would have done. And if I have a woman who tells me, or a man, if I have a woman who tells me I want to be curvy, I don't want to be too square, then I can make that scar a bit shorter, knowing that they will see that emphasis as an advantage rather than a disadvantage. So that's some of the things that we think about. How's that? Have I answered?
Yes.
I say in 1 minute what I can take 10 minutes to spell out.
I think that's what people are here for. They want to hear you discussing these things.
Cool. Yeah, you mean the injections? So that. Hey, you lovely people. I waved at you. Oh, matey, I haven't seen you for a while. Hope you're doing all right. Wonderful. We'll definitely come and see you. Please do post images. Yes, I will. So that was images for the dark circles. Yeah. So this one is this.
It's on Instagram.
Is it on our Instagram?
I'm pretty sure.
I don't think it is. I think it should be.
It's a man.
It's man. And the reason I think it's quite helpful for it to be a man in a way is that I think fillers, everyone has seen people with bad fillers, and I get so many people coming in talking about filler. Hello, stranger. I get so many people coming in desperate to avoid that bad filler look, and they all know what they mean. It's the sort of really obvious, thing. And It is quite stigmatizing in some circles for a woman to have really bad, but I tell you what, if you're a man and you've had filler and it's obvious, then you know you're staying in for the next year, right? You're not going to football practice, you're not going to the pub with your mates, you are going to be mocked mercilessly. So this guy wanted his tear troughs to be improved, and I recommended surgery, blepharoplasty for him. He said, no, I just can't do that. I'm forward facing, I cannot take 2 weeks off work, I own my own business, really busy, cannot do this. So we treated him with filler instead, and I'm going to show the photo in this spliced bit of the video here when I can, when it's no longer live, and give you an idea of what can be achieved. But just really natural. It does not look like this guy has had anything or needs anything, which is kind of what we're going for. Okay, we'll definitely come and see you. I cannot wait. And I'm sorry I called you Claudia when it should be Claudia. Clearly, I'm very sorry. I needed my lovely wife to just spell that out for me. Okay, going back to the messaged in questions. Is it ever possible to use other neighboring tissue, such as excess underarm tissue, in an auto-augmentation mastopexy? Okay, so the auto-augmentation mastopexy I was just talking about was the one where you've got sort of kind of droopy breast tissue, and you can use what would otherwise be maybe discarded to stack underneath the breast. But yeah, we can. There's lots of neighboring tissue that can also be used. And again, this borrows some of the techniques from breast reconstruction. There's one actually I've got lined up for quite soon. And this is a woman who would have needed a corset abdominoplasty. So a corset abdominoplasty is where you're sort of basically tightening everything like a corset. So there's a scar at the bottom, there's a scar up the top, there's a scar underneath the chest all the way, and it can even extend around like an upside down extended abdominoplasty. Now that scar at the top is because there is so much, you're essentially doing a reverse tummy tuck at the same time as your fleur-de-lis tummy tuck. Now, instead of throwing that away, you can, if that person is indicating they would like to have more breast volume, you can keep that and you can slide it north underneath the breast. Take the skin off that, support it, suspend it right up, and you can use that to add volume. And you can do that in addition to the other things that you can do to add volume, like an auto-augmentation mastopexy and fat grafting and reduction of the width. So you can add all of these things together. The particular hazard, I would say, with using the abdominal tissue is that gravity wants to have its way, and it's going to want to pull down. And when it wants to pull down, it's going to want to take the whole breast footprint with it if you've used that. So you've just got to maybe not be as fruity with it as you want, maybe not be as quite as enthusiastic. You think, oh yeah, I can get loads, and look how much I'm pulling up the tummy, it's brilliant. But it is going to want to fall back down again. So you've just, as the surgeon, got to slightly calm your pants with how much extra volume you're actually going to achieve versus how much you want to achieve. That's the first thing. Secondly is you've got to support it multiply. There's no point, finding this bit of tissue and taking the end of it and stitching it where you want it to be. You've got to be doing rows and rows and rows of stitches and really support this gradually and take the tension off it all the way. Otherwise it won't work so well. But yeah, you can. Now you mentioned underarm tissue. If you mean this kind of stuff here, then yes, you can. You can, and you can slide it in, and you can use that to augment as well. You don't get that much volume from it, is one disadvantage usually, and it tends to sort of pucker at its origin and sort of pull and distort that outside of the breast a bit. And whereas a really attractive breast has got a nice, clearly defined side boob, whereas you're sort of doing the opposite. You're creating a tendency not to do that. So that's a bit of a disadvantage. You can get around that by really finding a blood vessel to it using microsurgical reconstructive techniques and just literally isolating that bit of tissue on its artery and vein. But I tell you, it's turning a really straightforward operation into an extremely time-consuming and more complex one with more risk of serious complications like that entire block of tissue dying and getting this horrible infection and open wound. So it can be done. more often done in a reconstructive setting. It's honestly, it's simpler just to remove that bit of tissue if you don't want it, and to fat graft or use an implant. Oh, I say, I like them. Okay, if the flare effect carries on, it's looking like it will. I might just switch that off.
Mine to put a warning on for people who.
Okay, anyone who suffers from seizures, please avert your eyes now. Okay, I'm just going to stop that from happening, and we're going to go without lights. Okay, I reckon that's the way to go.
Every week.
There's some technical problem every time. So yeah, you can. Now, this is using tissue from under your arm to augment the breast. Now, I wonder if you were talking about this tissue, because this is obviously a target that people really don't like often. And that one is a no, as far as I'm concerned. That's just a fact. No, nada, mille point on that one. And the reason is, just for this to be alive, for it to survive, it's got to have a decent blood supply. And you're not going to get tissue that sort of may end at your elbow to your armpit on a decent blood supply, tunneled all the way through here. It's a great idea. It's a lovely, it'd be great if we could make that work. But no, not in any kind of, you know, aesthetic, proportionate way. So, no. But yeah, there is other tissue that can be used. You can, of course, use the breast reconstruction techniques. You could do a diet for breast augmentation. You could do an aesthetic diet. So you'd have good volume, good blood supply, a lot of tissue. You'd get a tummy tuck thrown in with it, and you know, it's a really well-established technique. But again, it is, you know, it is not cost-effective, because it's a, you know, breast augmentation with implants, 1.5 hours, straightforward surgery, very easy. Breast enhancement with a diet flap, what, 6 hours, something like that. And then close monitoring in HDU. The surgeon's got to be available to reoperate on you if there's a problem at short notice, certainly for the next 48 hours, if not 72. And it's sort of, you know, you can just, you know, complexity, complications, cost, everything is just skyrocketing. So yeah, these things are possible, but they're kind of not really done. You know, never say never. Okay, so going back to these, look at these lovely people. Oh my gosh, I haven't seen you for ages. Hello.
We need some more. We need them send live questions.
Oh yeah, so any questions on your mind, please add them in the comments. Are there any here in this little bit here? No, none there. Okay, so add them in the comments. Otherwise, I'll go back to this. So those are the two mastopexy ones there. Oh, had this one. This is nice. Does Fulvio offer treatment for excessive sweating?
Oh yeah, we just had that.
I know. Here it is. Does Fulvio offer treatment for?
I forgot to put it in the list. I'm glad you found it.
I picked up on it. Does Fulvio offer treatment for excessive sweating? Yes, yes, we do. So excessive sweating can be really, really embarrassing, right? It's sort of, you know, it can be uncomfortable when you're shaking hands. It can be socially embarrassing. We're not doing any handshaking at the moment, so maybe coronavirus is good for one thing. Yeah, it can stain through clothing if it's armpits. It can be uncomfortable in certain footwear if it's your shoes. So it can be a serious problem, actually. And yeah, there are treatments for it. Your first port of call should be your GP, because there are things that they will go through. There are antiperspirants they will use, some of which are strong enough to be prescription ones. They may want to do checks for things like, are you hypothyroid and things like that. So let's get all of that stuff out of the way. But I'm presuming it is sweating that is not responding to that sort of thing. Then the treatment depends on where it is. If it is excessive sweating of the armpits, which is a very common place, and the really heavy-duty antiperspirants haven't worked, then Botox is a really, really good option for that. And Botox works by stopping muscle contractions, as it does with all of these things. It's, you know, stopping muscle contraction. But the way that we're able to sweat is each hair follicle has a little gland which produces sweat with a little duct that passes into the follicle, or into the sweat, directly into the skin, I should say. I'm talking about sebum, but actually sweat glands come out directly into the skin. And those little ducts have a muscle around them which is able to contract. So Botox prevents contraction of that, and you are unable to sweat. It's really handy for armpits. It's palms of hands, soles of feet. It is a less kind of convenient treatment options because we can inject under your armpits relatively painlessly. There's a few injections, but it's not so bad. We can use topical numbing cream, and it's not so bad. When it comes to the hands and the feet, they are really, really painful if we were to just inject them. So under those circumstances, we do have patients who come with palms of hands and soles of feet problem, but in those situations, to make it painless, you have to do things like nerve blocks. So you're putting wrist blocks in, ankle blocks in, and injecting those under block. Wrist blocks are pretty straightforward to make work. Ankle blocks are trickier and more hit and miss. You may get a patchy block. There's one poor patient I have who comes and has this done quite regularly, and she'll be there waiting for her ankle blocks to work, and then she'll sort of, you know, grimace and get through it, and, you know, get through it, bless her. And then she'll go home, and I'll hear the next time, it's like, yeah, that block was working really well. About 2 hours later, oh, sorry. So it's not quite so convenient. For palms of hands and soles of feet, there are alternatives that may work not better, but be a bit more convenient for you, that they're painless. And there's something called iontophoresis, which is basically like a water bath through which an electric channel is passed, and you put your hands in it or your feet in it, and you repeat that treatment many times, and it improves sweating, and it does work. But again, it's not somewhere you want to go and have it done, because you need quite a lot of treatments. You need several a week, and you can step down the number of treatments you have the more you're doing it. But at first you need, do it daily or alternate daily, depending on how much you're sweating. And to sort of sit there, it's not so bad for your feet, because you can still be on your laptop or watching TV or whatever. But if you've got your hands in this water bath, then you can't text, you can't use your computer, you can't do much, you can't really even that comfortably watch TV because you kind of sat upright. It's really inconvenient. So compliance is difficult with iontophoresis. So I do think Botox is the best option for refractory cases, but done under block, which is not so ideal. But yes, we do offer that treatment. So whichever bit of your body is affected, we do offer that. We will find a way. We will make it work. Okay. Next one. Are you currently doing minor surgery? I have a pilar cyst on my scalp that I'd like to have removed. So please provide quotum relevant info. Right. Yes. Well, I'm sure we can provide a quotum relevant info. And yes, we are doing minor surgeries. We're doing minor ops at all the places we hold clinics. So whichever peripheral hospital, and our own clinic as well as a minor operating room. A pilar cyst, in case you're wondering, congratulations on using the correct terminology. So it gets called a sebaceous cyst often, and a sebaceous cyst is basically it's kind of a lump, a cyst. When you think I've got a cyst, you're probably talking about a so-called sebaceous cyst. And a sebaceous cyst is this blocked hair follicle that I started talking about when I meant sweat glands earlier. And if that sweat follicle gets blocked, then the oil-producing gland attached to the hair follicle doesn't have the sense enough to stop producing oil. And so if that happens, it just swells and swells and swells and swells. And the follicle that it originated from gets forgotten, and it just becomes this great big lump. But there's signs that it originated from a follicle. And that sign is it has this kind of big, open pore at the base of it. And whereas if it's a fatty lump, you can roll it around in quite a few directions. With this, you can roll it from side to side, but it always seems to tether at the open pore. And that's how you can distinguish from a fatty lump from a sebaceous cyst. Now, sebaceous cyst is what they always get called, but it's the wrong term. The correct term for a sebaceous cyst is an epidermoid cyst. And this is something you'll go through your entire plastic surgery trainee career not realizing until about a week before the exam, when someone, if you're lucky, tells you that the examiners get really annoyed by people calling them sebaceous cysts, and they will downgrade you. Epidermoid cyst is correct. Sebaceous cyst is a sort of anatomic, it's just not the correct term. And when it comes to the scalp, it's not even called an epidermoid cyst, it is called a pilar cyst. And a pilar cyst is an epidermoid cyst of the scalp. So I'm just seriously impressed by your knowledge of pilar cyst. Yeah, you're right, yeah, absolutely right. You're telling me that you've got one of these on your scalp. I've actually found one too, I've got one on the back of my head.
I know.
And you keep telling me to stop scratching it.
I do.
But I don't, I keep scratching it.
You do?
Yeah.
And is that good for your pilar cyst to keep scratching it?
It's
Is
not
it the right thing to do?
it's not so good. I mean, you might cure it. I don't recommend you do this. This is a do as I say, not as I do moment, I hasten to add. So don't do what I do with them. They used to say, oh no, that's ganglions. No, they never used to say smack it with the Bible. Don't do that either. It won't work. It's not even the right anecdote. So just forget I said that. Okay, I'm going to check the live, but I don't think. Oh, right. Okay, now we have Melissa Pi X. And is it? I've always wondered, is it Pi X or is it Pi and then a little kiss or a hug or a virtual one? But anyway, will you be getting the Morpheus 8 machine in your clinic? What do you think about that?
We have a big long list of things we will be getting for the clinic.
So, Melissa, as Beck says, we have a big long list right now of things in the firing line for getting into the clinic. And I think it's fair to say that Morpheus 8 is not in the top 5.
Oh.
Is not in the top 5. Newsflash, you put it here.
It's in my top 5.
Is it really?
Yeah.
Did you like it? Why? What have you heard?
That's very good thing.
You've heard very good things. I've heard very painful things. So, yeah, indeed. And we have a few patients who I think it's almost fair to call them professional patients, who go to many clinics and have many treatments and are real experts on having treatments at clinics. And I really kind of welcome the opportunity to spend half an hour chatting to these people, because you get the gossip in a big way. You know who's doing what and where and how well it works. You know, they're a font of knowledge and they want to tell you, they want to talk. And the thing I keep hearing about Morpheus 8, so I hear good things about Morpheus 8. I also hear it is severely ouchy, and I also hear it is not particularly, it doesn't really seem to have any advantage to one of the treatments we're already offering. I don't think. I'll talk to you about that later. And the main competitor for it on our shopping list is another slightly more invasive treatment. And I'm not going into this too much because I don't want to say we're getting something and then it be months and months and months before we get it. But we are actively looking at a couple of things. And I think there is something for me that is substantially better than Morpheus 8 that I would really like to get well before that. So I'm going to be swamped now by the Morpheus 8 marketing and rep people, no doubt. I'm sure it's brilliant. Bex really loves it, but we are at, the correct answer is we are evaluating, but
We're always evaluating.
We are
We're
always
looking into new treatments.
We do hear really good things about it, but it, you know, with the portfolio we've already got that offers a lot of what it would offer anyway, and with what we're looking to bring in, there's kind of not much of a gap. Sharon, hey Sharon, what does Morpheus 8 do? It's mostly for facial rejuvenation, skin tightening, that's and neck as well. So, and it's, you know, look it up. It's Morpheus. It's not Morpheus. Morph E-U-S. Like that wasn't that a character in The Matrix? Morpheus. Yeah, he was a character in The Matrix. I don't know where the 8 comes from, because as far as I'm aware, there isn't a Morpheus 1 to 7. But yeah, thank you. I'm sorry. You know, I hope that's not really disappointing for you. But I'll give you this as a principle. I would recommend that you approach wherever you go for your treatment. Yeah, exactly like that, Sharon. Yeah.
You say that, but nobody knows what the colour is.
She said so, like Endymed.
Exactly.
Yeah, right.
Endymed.
So I would approach your practitioner with what your problems are, what your concerns are, what can be done first. By all means, have treatments that you think will address it, but go with the problem, not the solution. Because if you go with the solution, then the answer will be yes or no, we have it or we don't, whether it's the best thing for you. If you go with the problem, then they may say, yeah, we have that, but we actually have this that will address that and this other thing better, or we don't have it and here's why. And just listen and evaluate. And if you're not hearing the treatment option that you were expecting, just say, you know, I was expecting you to offer me this. Is there any reason you haven't? But I think that is the best approach to have to it, really, rather than going with the particular treatment. And the truth is that a practice will evolve based on what its patients and its population ask for, and their expertise, and what they already have, and what complements it, and what adds to it. And I really resist. So there's a particular type of liposuction, no names. There's a particular type of liposuction that is heavily marketed to patients, and then, you know, heavily marketed directly to patients, and then patients come in asking for that. So the marketers have done a great job, but what they should really be doing is the more difficult job of promoting it to the practitioners as a genuinely better solution. And you kind of got to be suspicious that it is not possible to do that if they're taking the sort of backdoor approach. So I like to look for the evidence first and foremost, and rather than just sort of follow the hype. And you can, because the hype will be a different hype every month, or, you know, every few months. And so you can go insane, and you can have a sort of little graveyard of machines that aren't that good. However, this one I really would like to get early next year. I'm very excited about. What? Yeah. Okay. Is it the same as Fraxel or just hyped? I can't say, actually. I'm not going to say it's hyped. It's new. It is new. It's got a lot of positive proponents of it, and I don't want to dismiss them. Some of them are my very respected colleagues. So I'm not going to say it's just hyped. I do hear good things about it, but I don't know that I've heard that it. When you then say, so what does it do? It does the same stuff, a lot of other stuff that does it very well, I believe. I haven't seen a USP, or a particularly compelling USP as far as I'm concerned. Let's go back here. So, right, over here. So we've done that. Now, tummy tuck. Should we go on for a tummy tuck one? How are we doing for time? Okay, 20 minutes to go, so get in there if you want. Is it okay to get pregnant after a, so I've heard a question there I don't want to answer, but I will. Is it okay to get pregnant after a tummy tuck? Depends what you mean by okay. So you can get pregnant after a tummy tuck. You will get through it. It will be fine. You'll have your baby. Baby will be fine. You'll be fine. But you shouldn't plan to be getting pregnant after your tummy tuck, because the tummy tuck will be ruined by the pregnancy. So yes, I mean, it's hard to say this. Ideally, it should be an unplanned pregnancy. You shouldn't really have been anticipating you were going to get pregnant. Maybe you should have been thinking about definitely completing your family and putting precautions in place so you weren't going to get pregnant. But if you do, yay, congratulations, baby. But you may not, well, you won't have the same tummy. You won't have the post-tummy tuck tummy, post-tummy tuck, post-baby. You'll have a post-baby tummy, post-baby. So, but it's true. So, yeah. Oh, Victor. Hey, lovely Victor. Fat grafting to the fat. Oh, and you know what? You might have dodged the previous question for me. No, I'm not going to dodge it. I'm going to answer that one first. So the question is, what are your theatre days? I'm on the waiting list for December.
Oh.
So, Bex, can you come in?
Oh, bless you. I know you're on my list for December.
So,
have you there.
Bex says she knows you're on the list. I don't. So, okay. When I start talking about operating list dates, I kind of get this big elbow in the ribs from the love of my life in the corner here, because I don't want to say I have no operating lists, because everyone will get stressed and immediately phone in and email in. And I don't want to say I've got operating lists, because everyone who hasn't been offered one will then immediately phone in and email in and get stressed. So I think every time I say the word operating list date on a FUB Club Live, I think your Fridays are generally pretty busy.
Yeah.
So well, yeah, busier. So that's the problem. We do know about you. Bex just looked over to see who posted the comments. Yeah, I know she really wants this, and we are in constant daily contact with the hospitals, and we are getting news. We are hearing things from them.
But it has stilted quite a bit.
Yeah, our amount of operating lists has reduced from a really healthy kind of loads a week, more than I think I'd ever operated before, to be honest, to less, a lot less. So it is constantly changing, and just because we don't have maybe a lot of lists now doesn't mean we won't tomorrow or next week or whatever. So we are constantly communicating. We've got great relationships with the hospitals. They are trying to do the best thing for us and for the patients and for the other surgeons and for everyone. So it is a constantly changing thing. I'm really sorry. I feel some of the pain, of the politicians, and I'm as kind of critical as anyone, but they keep giving everyone a different story, and I kind of think what they need to say is, look, the situation keeps changing and we are changing with it. And I think everyone gets that the situation is changing, and
it's the same for us.
And it's the same, very much the same for us. So every operating list we currently have has been allocated, but we are getting more lists, and there is a pipeline, but we are always being told that these lists will become available to us only if they are not put to use by the NHS. And that does happen. So it's the kind of the same thing. We don't get much notice.
Today we are in negotiations for October.
Yeah, exactly.
So
and that's fair to say as well. So right now, as of literally today, we are speaking to a hospital about the realistic possibility of getting some extra lists in October. And we're not even having the conversations about December yet, to be honest with you. They're they're not letting us have those conversations. So that's where we are with that.
No one knows where we're going to be.
Yeah, it's so uncertain. I heard a journalist ask a politician about whether students would be allowed home for Christmas, and you kind of felt, what's even the point of asking that? They can't know. And they said, very not unreasonably, they said, look, we don't know where we're going to be in November or December. We just can't really answer that question. So there you go. I'm not trying to compare myself to a politician. Damn, what's happening to us? Okay, I'm going to go back to the other question. So, Vixter, fat grafting to face versus fillers. Yeah, it sounds so attractive, right? So fillers, we can do all sorts of lovely things with fillers, and fillers are great, and let's have volume with fillers, and we can, project bits of the face more, and it's really a lift, but you can sort of tent up bits and create the illusion of a lift, and you can change, if I had a light, I do have a light being straight down, you can change the bit that light bounces off, the so-called light reflex, and if you change it from kind of there to sort of there, I suddenly look like I've got cheekbones. So you can do all sorts of optical tricks with fillers. Great. Trouble with fillers is you keep needing to have them done again, because they last 6 months, 12 months, 18 months. Some of them last up to 5 years. That's sort of out the limit. But ultimately, you've got to have them redone again. So what about fat grafting? Well, fat grafting, you take it from one bit of the body with liposuction, bonus. You then inject it instead of filler, and it's your own stuff, bonus. And what survives longer than about 2 or 3 months is permanent, bonus. So why wouldn't you want to do this? For my tear trough, you're saying, yeah, right. Okay, so why wouldn't you want to do this? Well, problem with fat graft. Fat graft is great. Fat graft is it's natural, it's it's permanent. What takes is permanent. But 2 things. First of all, it's not structural. And I mean by that, it doesn't have its own, it doesn't project much. if I get some filler out, and I see practitioners doing this, and I always think, what are you? You know, you've got money to burn. You know, you Beyonce and Jay-Z or something, because they'll get their filler out and they'll go, oh, look at this, and look how it stacks up. Which I don't really do, because that's 200 quid of filler they just wasted. I guess it must have expired. That's the only reason you do that. We're too busy. We don't expire after. Oh, come on, you're not going to do that with us. Anyway, and they do it like, look at this one compared to this one and that one. You've just wasted $1,000 for this 5-second Instagram post. That's ridiculous. But anyway, fillers have a varying amount of cross-linking and cohesivity. Cross-linking determines how thick they are and gloopy. And if they're very cross-linked, they can have a high projection ability called the G prime. And when we're trying to sort of augment and project, we want that kind of thing, high G prime. Whereas if you want a soft kind of lip type thing, we want a very low G prime. We use the softer ones for the teardrop area, so actually fat is a bit more appropriate there. But that's where the second point comes in. So fat is not great for doing things like cheeks and projection and structure and definition. Definitely a bad idea for jawline and chin projection, I think. But not such a bad idea in principle for the teardrop, except for the second disadvantage, which is this. Where do we get the fat from? We get the fat from fat bits, so thighs, tummy, whatever it may be. Now, the thing with our fat bits is, as we get older, our fat bits get fatter. And if it's, you get a bit of middle-aged spread around your tummy, you get chunky thighs or whatever it may be, then you can wear baggy trousers or a looser shirt or whatever it is. But if it's now on your face, then you kind of, you just kind of end up looking like a hamster. And the only way to stop looking like a hamster is to be slim enough that your fat is not enlarging. And so you might think, okay, well, you can go back in and liposuction it out. Liposuctioning a face is no joke. That's not much fun. And you are just as likely to hit the fat that you didn't graft, the fat that's meant to be in your face, versus the fat that you put in that originated from your belly or your thighs or flanks or whatever. So I have met and spoken with practitioners who did this early on before we kind of appreciated some of the downsides, who kind of really regret it now, and they will openly say that they think they look a bit funny as a result of it. So it's not something, I'm not going to do it to you, Bixter. Now, I do some fat grafting during a facelift, having said that, and I will put some there, having said that. But I would only do it as part of another procedure. I wouldn't really do it on its own merits, because honestly, I think you're going to be so underwhelmed by the results of it. I think it adds something to something else, but I don't think it's, you're going for surgery, right? You've got a scar somewhere else. You're having something done to your face. You want to look really fundamentally better. And I just think you're not going to see enough of a difference with the amount of volume I'm happy to put in, so you don't get kind of middle-aged spread of your eye bags later on. So I don't think it's, for me, not such a great option. There are other things you can do with fat, though, for facial rejuvenation. You can do things like nano fat and all sorts of things to improve skin quality. That's a good thing. Hey, Jenna. Right, Jenna. Hey, thanks for tuning in. We've got to get you on here because we keep getting non-surgical questions, and I keep saying, let's bounce them to Jenna. And so we need to get you on because we keep bouncing the non-surgical stuff. Agostina's here.
Ciao.
Ciao, Bella. Ma come stai? It's been too long. We need, haven't seen you and your lovely husband for too long.
No, because she's been asking to come in.
Oh, really?
Yeah,
How funny.
We are absolutely back to
well,
back.
Well, I didn't get that message, but for you, we will drop everything. I mean everything, right?
Okay, you can ring the patients and cancel them.
Miss you. We miss you too. Bex has just volunteered me to ring all our patients and cancel them so that you're free to come in. So just do it. Sharon is saying, Jenna, Sharon is saying, come on, you're fab. You are fab. We know you're fab. Sharon, I don't know if I can say this. Anyway, you're fab. We were talking about you earlier, Jenna, and you're fab. Right. Okay. I'm going to dig myself also. I'm going to move away from that. I'm coming. She's coming. She's camera shy. Don't be camera shy.
Jenna is camera shy. Bless her.
Okay.
I don't know why, because she looks better than.
I mean, so Jenna, to those of you who haven't met Jenna walks around life like she has this Instagram filter kind of in front of her with this kind of flawless skin floating through the clinic. So, I mean, people won't believe it on Instagram that there is no
She's
filter.
like a graceful, beautiful,
Lovely person.
lovely, loveliness.
Graceful, beautiful, lovely person. That's how we described you. You are gorgeous, says Sharon, and Sharon knows. There you
Yes,
go.
Jenna, you
We're
are
getting lots of
gorgeous,
heart to
gorgeous,
this.
Gorgeous.
Now, there's a little question in my funny little question icon. Oh, let's see. Can I post this? There. Tap a response to show it on screen. Yeah. Hey. Okay.
They might want that to be private.
Nah, I don't say. So the question is, independent of a tummy tuck, can a belly button be revised easily? And so, if so, is it under general anaesthetic or local? Short answer? Shall I do a short answer?
Yes.
Yes. So yes. Oh, lovely Jenna. We're still getting Jenna comments. There is lots of love for Jenna. You've so got to come on this. So yes, a belly button can be revised. And we asked last week, but because of all the technical problems, I don't think we got the chance to answer it, but it was, got it here. What is the commonest revision procedure after tummy tuck? And I would say the commonest revision procedure after tummy tuck is belly button.
Yeah.
Yeah.
People have a funny impression about
Session, because I have.
I think a lot of people are unrealistic about what belly buttons actually look like.
Well, that is true.
Once they've had a tummy tuck,
That is true.
I think they forget that belly buttons are these really funny wibbly wobbly.
So what I would commend to you is to look at people's tummies, people who have not had a tummy tuck, and look at their belly buttons. And you know what? They're odd. Some of them are a bit odd. They've got little knobbly bits inside. They crease, they curl. Some of them have double knobbly bits. I mean, they're very variable and they're a bit odd. And fundamentally, we're unlikely to make your belly button more beautiful than it was at its most beautiful. Jenna is saying, okay, I'll come on. You've guilted me into.
Yeah!
I'm happy.
I mean, I don't want to feel guilty.
Oh, don't feel guilty, but please do come on anyway. But not feeling guilty. So this is good. Yay, Jenna. Hearing the Jenna love. Yay.
I'm not sure it'd fit three of us in this room.
Are we going to link you in, or are we going to do it in?
Oh, yes, you can be. Oh, yeah.
Or are we going to do it in the studio?
Minus we'd be under 1 meter, 2 meters.
Yeah, I know, but we're in the same bubble.
Oh, we're in the bubble.
We're in the same bubble.
Oh,
It's
I
okay.
know.
We're in the
These
same
things
bubble.
you have to think about.
Okay. Anyway, yeah, yay. We'll make it work. Thank you, Jenna. So yes, and the reason that belly button, so tummy tuck, big scar, lots of tension, but it's been taped in my practice for 3 months, and scars tend to be lovely and fine and nice. Belly button scars, we can link you in. Yeah, we will link you in. Belly button scars, you can't tape for 3 months. And the trouble with the belly button scar is, so I try to hide the bottom bit of the belly button scar by making it a flap of skin and putting it inside the belly button, so the scar actually runs internally. Call that a sad smiley face technique. For the top bit of the belly button, the scar is sort of on the edge and on the rim of the belly button, but even that, I'd like it to be internalized somewhat. Sometimes it works better than others. Works better on bigger people rather than slimmer people, because they've got more thickness of the abdominal wall to hide the belly button scarring. But the only way you can internalize it is by really sort of shortening the stalk so that the outside skin is pulled inwards. And if you shorten it really well, then it goes in, and if you can't shorten it so well, it doesn't. Now the trouble is, you're trying to, I don't want to use external stitches because that will leave stitch marks, so you're trying to bury all your stitches and use dissolving buried stitches, and you're not even closing end to end, you're closing edge to edge, you're closing kind of at a right angle, down a hole, and it's tricky. And then you can't support it or tape it, and so these unfortunately, you can start with a lovely internalized scar, and then it can kind of stretch and pull, and it starts to externalize, and you've got this widened scar that's externalized. So, which is annoying. So yes, that can be revised, and it's a scar revision. It's local anesthetic, can be done in an outpatient setting in the clinic, and it's relatively straightforward, and it is less likely to externalize again because we are pulling things a lot less hard. I have to say, more recently, and it's the last maybe 7 or 8 cases, I'm doing that bit of the belly button slightly differently. And it occurred to me that it's really difficult to do this from outside because you're going down a deep, dark hole on the acute bit of an angle. But actually, if you do it from inside, it's easier because it's now at the surface facing you, and it's the outside edge of an angle. It's much easier. So you've got to clunk your head around a bit, and you're doing everything back to front, but it's actually much easier. So that's what I've started doing the last, I guess, 6, 7, or 8 cases, and it's worked really well. But yes, belly button revision can be revised relatively easily. The only time it's really quite tricky to revise a belly button is if you get total breakdown, total dehiscence, which means the entire circumference of the belly button stalk comes away and internalizes, and you're left with this kind of scarred stump and nothing attached to it. And I tell you, that that is tricksy. And that you would probably be encouraged to have a GA for that. But under other circumstances, and really, God, that's got to be rare. Under any other circumstance, it's relatively straightforward to revise it, and local anesthetic should be pretty easy.
Was that the short answer?
That was a short answer. Okay, 3 minutes to 8, guys. So I'm going to wind up. If you've got any live questions, then go for it. Otherwise, I'm going to end on a breast question. I don't think we've done a lot of breast today, have we? We haven't, unusually for us. Oh, yeah, we did. We did all the mastopexy stuff earlier. Okay, this one was, I've been told that I need a breast lift, but I'm okay with my boobs how they look now. I know it won't lift them, but would an implant still give them more fullness and volume? Okay.
Why do you do that? You need to explain the thing.
Why do I do that? Because I've been told that in a breast lift, so I presume you have some breast droop, but you're okay with it, which is great. That's fine. Love that you're okay with that. But the thing that looks much worse, in my view, say hello to Rebecca from Agostina. I'll see you very soon. She's checking out. So bye-bye, Agostina. See you soon. Okay. The thing that looks worse, I mean, when I say worse, I mean a lot worse than droopy breasts. Droopy breasts are okay. People have droopy breasts. You get older, your breasts may droop, and that's okay. But what happens when you get older and your breast droop is you don't have lots of breast volume at the top with then a bit hanging off the end of it. That's bad. That looks bad. So the thing that looks a lot worse than droopy breasts is droopy breasts with a breast implant in them. So you could well, doing the approach that you suggested, go from having breasts that you're okay with to having breasts that you're not okay with, because they are breasts that are drooping on top of breast implants. And you can end up with this kind of full top, droopy bottom. It looks kind of unnatural. And it's the unnatural that is unaesthetic. So I would say no. If you've got droopy breasts, there's a kind of hierarchy of surgeries that you could have to improve things. First, very reasonable option, nothing whatsoever. Leave them alone. You like them, leave them alone, fine. Second, minimum entry level is an uplift. It's an uplift of some kind. Third, uplift with implants. And then there are various other permutations and type of uplift and type of implant and type of plane and whether you have fat grafting and this and that. But, you know, I would say uplift, if you've got droop, any significant droop, is your entry-level surgery. And nothing is better than just sort of skipping past that and going for implants. So I would say no. I'd say don't do that. I think that's a bad idea. And I would discourage it. So there you go. And I guess I do a lot of breast augmentation with uplift. You know, if you're young and you've never had breast surgery before, then primary breast augmentation, love it, lovely operation. But you're older and there's some droop and you're going to add volume, then your shape has got to be just right. You can't have high, youthful volume with non-youthful shape. I've got 20 seconds left, so I'm going to say goodbye. Should we say our goodbyes? So guys, thank you so much for tuning in. It was lovely, 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 lovely to see you and so many lovely people. And we've persuaded Jenna to join us, which is definitely a bonus. So we will, let's do it next week if Jenna's free. Okay, we'll talk to her now. Bye-bye. Enjoy the rest of your Thursday night. Bye, guys.